Before we get started, I just want to review a few housekeeping items so everyone can understand how to participate in today's webinar if you choose. So first, we have the viewer window, which is what you are all seeing right now, and the control panel. And the control panel can be opened and closed using the orange arrow. And so to participate in today's webinar, you can do so over audio, over the phone. Everyone is muted. All attendees are muted right now. If you'd like to be unmuted to ask a question at the end of our session, then you can just raise your hand and I'll unmute you. You can also, this is the audio pin that you'll have to use if you'd like to speak over the phone. And then you can also submit questions via the questions box, and I can read them to our presenters at the end of the webinar. And there will be time for question and answers. And then also we record all of our webinars, and they'll be posted on our network YouTube page. So now I'm going to hand it over to Dr. Corey, who's going to introduce today's speakers.
Great. Thanks very much, Audrey. And I want to thank everybody who's tuned in for today's webinar. We're going to be discussing healthcare disparities in individuals with autism spectrum disorder. This is one of our primary initiatives with the current AARC project. And today we'll be hearing from John Garrick from the University of California at Irvine program, from Rolanda Gott and Katie Schaff from the Knights of Columbus Developmental Center and St. Louis University program within the AARC. I'm going to turn things over now to Katie Schaff.
Hi, Dan. Actually, it's Rolanda. I will start first. Next slide, please. So thank you, Dan, for the nice introduction. I'm very glad to participate in this presentation that addresses healthcare disparities in autism. And as you said, this is one of the top priorities of Autism Speaks, ATN, and AARC for both standard of clinical care and research. Next slide, please. Actually can go back. Sorry, go back. Yes. During this webinar, I will present what is known in the literature about health disparities in autism. I will then introduce you to the goals and activities of the Healthcare Disparities Work Group. Jean will continue the presentation with an update on the results of the Healthcare Disparities Survey that was completed by all 14 ATN sites, so thank you, everyone. After this, Katie will share with you an innovative and very interesting method of assessing catchment area in comparison with service area of an ATN site. She will then continue to talk about what will be the next steps in finalizing the data analysis on catchment and service area for each ATN site. She will also present specific recommendations on how each site could identify which population from their catchment area has limited access of care, as well as which are the site-specific barriers to care, and actually, most importantly, how can each site reduce those barriers to care? This would be a big challenge for all of us. At the end, we will leave 15 minutes to address questions. Next slide, please. So ideally, everyone should receive the same level of high quality of health care. Unfortunately, even in the United States, where overall there is advanced medical care, there is still disparity in the health care received by those with low income, low education, as well as minorities. And also for those living in rural areas or patients affected by disabilities. As a result, this is so-called vulnerable populations tend to receive poor quality of care, and they many times have decreased access to care, and as a result, they may have poor health outcomes. Before reviewing what is known about healthcare disparities in autism, I would like to clarify that our group used the HRSA definition for health disparities. Next slide, please. So HRSA considers as health disparities the negative differences seen in the length and in the quality of life of a population or group, as well as the differences observed in the severity or rates of a disease or disabilities. These differences may be caused by multiple factors, such as lower social position, certain race or ethnicity, gender, and sexual orientation. For example, there is a health disparity in the obesity of Black U.S. population that has a much higher rate and a higher severity when compared to non-Black population. So next slide, please. So why do we need to talk about health disparities in autism? We want to talk about this because as we make significant progress in early identification, interventions, and biomedical research, we also want to make sure that all children with autism have access to the same level of high quality of care. As I was reviewing the literature, I realized that we have started to identify many types of health disparities specific for autism even. But now our challenge remains, and our task, to understand the complexity and the multiple barriers to care faced by patients with autism, and what is actually causing the disparities, and most importantly, I believe, and of course challenging will be again to decrease and eliminate the disparities we will identify. Research has shown that although we are making progress, we still can see racial and ethnic and socioeconomic disparities in the identification of autism. In general, I was seeing that Blacks are less likely to receive an autism diagnosis, and both Blacks and Hispanics are more likely to be diagnosed with a different diagnosis, such as intellectual disability instead of autism, for example. As a result, we have seen an underestimate of the prevalence of autism that is lower in Hispanics when compared with non-Hispanics, and in non-whites when compared with white population. In addition, we have seen also a lower prevalence of autism in poor children, due most probably to the limited access to diagnosis and care. Next slide, please. Overall, we have made continuous and significant progress in the United States as far as early identification of autism as early as 18 or 24 months of age. And we also were able to decrease the mean age of diagnosis of patients with autism from 8 to around 4 years of age. Despite that, we still see disparities in the age of autism diagnosis for children with low income or low socioeconomic status. African Americans and Hispanics are also diagnosed later. Children from certain areas with limited resources, such as rural areas and certain states, continue to be diagnosed later. At our site, for example, in St. Louis, due to state and medical insurance policies, there is a health disparity that is severe between patients that are coming from Missouri versus those who are coming from southern Illinois. And Illinois patients, and especially those with Illinois Medicaid, have much more limited access to psychological evaluation and in general to clinicians with expertise in autism and diagnosis disabilities. Slide please. So disparities were identified in general not only in diagnosis, but also in the treatment of individuals with autism. And in general, we have seen this also among special healthcare needs children that continue to have a higher risk for unmet health needs for specialty care and therapy. But this is even higher in children with autism. In addition, parents of children with autism tend to report much more frequently that providers lack expertise in treating their child, even when compared with providers who serve a child with special care needs. Next slide, please. So special education services are free and are crucial in providing intervention for low-income population that has limited access and coverage for private therapy. Unfortunately, exactly the kids who need more, the kids with low socioeconomic status, tend to receive less services through special education. In addition, research has shown that non-white population with autism tend to have disparities in the access not only for education, but also for medical care, to access to medical subspecialists in different fields, and in receiving specialty treatment as well as medical testing. Blacks, Hispanics, and poor children with autism also have lower access and quality of primary, so not only specialty care, so they have a lower access to good quality of primary pediatric care. A study done by Dan Curry and Patty Manning showed actually that non-white children also tend to use less psychotropic medications. Next slide, please. It is well known that as we are making great progress in the early diagnosis and treatment, there are still huge disparities in services for adults affected by autism. In order to improve adult services, we do need to improve transition services and planning for youth with autism. Although all individuals with special healthcare needs struggle with the same issue, meaning to receive transition services, researchers have identified even a greater disparity again for youth with autism when compared with youth without autism and other special healthcare needs. These disparities in services are even higher in individuals with autism who also have high level of comorbidities. Next slide, please. Next slide, please. Yeah, next slide. So as I previously mentioned, ATN, Autism Speaks, and AARC are highly interested to identify and address healthcare disparities among individuals with autism. As a result, this year, a healthcare disparity work group has been created. Our work group has monthly conference calls since February. The work group has four lead sites, UCI, SLU, Toronto, and Arkansas, and a larger representation of clinicians, parents, and resource specialists from other ATN centers, such as Alberta, Rochester, and Cincinnati. I would like to take this opportunity to thank Dan Curry, Donna Murray, and Gabby Hurtado from the ATN lead team for the support and guidance our work has received until now. Next slide, please. After reviewing what is known and what is unknown in health disparities in autism, our work group came up with two hypotheses for our project. First, we hypothesized that low socioeconomic status, ethnicity or race, the type of medical insurance received by patients, needs for transportation, location of the family, the level of literacy, language and culture may be important barriers for access of care for patients with autism seen at our ATN clinics. Our second hypothesis was that there could be additional and even higher barriers to access of care among certain individuals from the catchment area of each ATN site that actually doesn't even access the care at the ATN site. Next slide, please. With this hypothesis in mind, the work group has identified three goals. Our first goal was to identify health disparities among patients and families served at all ATN sites. In order to get this information, all 14 ATN centers completed a survey in which sites identified specific characteristics of what they consider to be an underserved population and on specific barriers to care at their site. Jean will share with you the results of this interesting survey. Our second goal was to identify specific characteristics of patients from each ATN catchment area that do not access specialty care at the ATN center. In order to assess this, sites were asked to specify the zip codes of patients with autism or disabilities as they receive the information from their hospital seen at their center, so the clinically served population as well as the zip codes of their catchment area. So basically, Katie will talk about an innovative method to analyze the differences between catchment and service area at each site. Once we have identified the type of health disparities and the high-risk population from catchment and served area, we now like to focus on our most challenging goal, and we need everybody's help, and this is to find ways to reduce barriers to healthcare disparities for all individuals with autism. For achieving this goal, we plan to host webinars and to provide consultation and to collaborate with experts in the area or in the field, and with all the ATN sites and experts, so we can increase the knowledge and raise the awareness of the high-risk populations who have high risk for unmet health needs in the field of autism. With this, I will actually ask Jean to continue and present. He will talk about the results of the survey.
Okay. Thank you very much, Rolanda, for the wonderful introduction to the topic as well as to our work group. I will be presenting results from the multi-site survey. Next slide, please. So we carefully developed a site survey that started in about at around April or May of this year, and we had a couple of items that we pilot tested at UCI, and then another round of pilot survey that was sent out a couple of weeks later. And we came up with a final survey in late July, beginning of August, when we rolled that out to all the sites. So thank you very much for responding to this survey. This survey included 34 items designed to assess the local, clinical, and patient characteristics of each of the 14 ATN ARP sites. And we came up with a post-hoc survey and analysis comparing demographic information specific to each site. So in other words, patients served at each site compared to individual catchment area, which is basically the neighboring communities, to see or get a better idea about who we might not serve and whom we might serve, actually. Next slide, please. So we asked 3 questions at the beginning. Number 1 was, what is being assessed at each site? It was very clear from the get-go that different sites assess different things, and we wanted to get kind of a map of what we do already very well and what we might want to standardize across sites. And then, of course, who is being served at each site and across the ATN. We wanted to make sure that we captured the diversity of each site in terms of who they serve. But then also the third question is, who are the underserved? And in the worst case scenario, those are the people that we never see, so they are hard to survey. But underserved are oftentimes people that come in with a late diagnosis as well. So we wanted to see, what kind of proxy measures we can have and what we can do to come up with some solid recommendations for the ATN to move forward and reduce health disparities. Next slide, please. So you can see here that 86% of sites are located in urban areas and 14% of sites are in suburban areas. There are no sites located in rural areas, so that's, of course, not very surprising because most medical centers are in urban and suburban areas. But interestingly, when you look at the graph below, you can see that more than 75% of sites report serving rural communities as well. So that was certainly encouraging. Next slide, please. We also wanted to see what kind of parent information is being tracked by the sites. And you can see that this is quite diverse here. There was only one site that tracked parent literacy level. That was one factor that was identified in previous research as a factor for health disparities. 36% of sites track parent education. 43% of sites track family socioeconomic status. Over 90% of sites track race and ethnicity. These are all the U.S. sites. The two Canadian sites don't track race and ethnicity. 71% of sites track primary language spoken, and 43% of sites track number of patients using interpreters. So you can see there's quite a diversity here in terms of what we're collecting, and we have most of the data here across the sites for race and ethnicity as well as language spoken. So I will be focusing on that in the following slide. Actually, next slide, yes. This is a slide showing the breakdown of percentage of patients by insurance type, and you can see that 54.1% of patients are covered by private and commercial insurance compared to 44.5% of patients on primary public insurance, and only a small percentage of patients are using cash pay. Next slide, please. So we were interested in patient ethnicity, and since we're working in a mental health field, building trust and building a therapeutic alliance or relationship is important. And so we were also looking at clinical staff and their ethnicity. And as you can see, non-Latino whites are 71% of patients compared to about 68% of clinical research stuff. So a little bit of a differential there. When we look at the Asian population here, the patients are consist of 4.4% of the ATN patient population compared to 4.7% of clinical staff. 10% of patients are African American, and only 2.7% of clinicians are. And there's a similar issue with a differential here with the Latinos, where you can see that patients are 6.2% compared to 1.1% of clinical staff. Next slide, please. Now, communication is important, so we wanted to also look at language. And you can see that 5% of clinicians speak Spanish, and the patients per group here are about 3.6% for Spanish language. So it's actually a positive differential. We're not doing too badly with that. However, it's very site-specific, and averages may be a little bit misleading. But from the averages, we can say that Farsi, Somali, Japanese, and Filipino or Tagalog are the languages that are least likely spoken across ATN sites, and there's a little bit of a mismatch there. Next slide, please. So we asked a question about who are the underserved or the most at risk for health disparities, and the majority of sites reported, or close to 80% of them reported that they feel that rural populations or communities are most at risk for being underserved, followed by low income, followed by limited English proficiency and education, as well as being Latino or African American. And a number of sites also pointed out that they view the publicly insured as the underserved, as well as being Somalian and Asian populations. And Asian populations, unfortunately, are not broken down here in the various subgroups. They're the different nationalities. They're culturally quite different, and I think in the future we have to maybe come up with some more of a breakdown here to really identify who is underserved among the Asian population. Next slide, please. So here you can see the activities that sites already engage in to improve access to care for any of the groups described above, and outreach is number one. And those are all broad categories with some overlap there. But under outreach, we had reports of outreach clinics and partnerships with primary care providers, refugee clinics, regional center and State Department outreach. Under education, we had parent and teacher training, language interpreters were also an option of reducing health disparities, particularly when it comes down to language. So here we had parent training, for instance, in Spanish or other languages. We had family support and mentorship programs, like family navigators at our site, for instance. For community partners, we had community partners in foster care clinics, churches, regional centers, etc. And then obtaining referrals from rural clinics and services was another activity that some of the sites engaged in. Next slide, please. One caveat of the survey was that we found out that different sites report on different population and different age ranges. So many of the sites reported on clinical patients with ASD only, and an equal number of sites reported on clinical patients with developmental and behavioral disorders, and a smaller number of sites reported on clinical patients seen at the medical center. So quite a diversity, and something that we have to work towards standardizing across the ATN. Next slide, please. So in summary, we can say that not all sites track patient ethnicity, primary language spoken, or parent literacy level. Less than 50% of sites track parent education and socioeconomic status, and none of the sites are in rural areas, understandably. Next slide, please. The highest percentage of minorities was among the African American and Latino communities, and they were not equally matched with clinicians, so that was certainly a problem. So there are only very few clinicians at ATN sites that are of African American or Latino background. There was a lot of variability in who sites perceive as high risk. but the majority actually agreed on that rural communities are the #1 at-risk population, followed by the low-income, low parent education, African American and Latino communities. And all sites report data and information in different ways, and that's something we certainly need to standardize or need to move forward in coming up with ways to standardize this. Okay, next slide, please. So I'm going to hand it over to Katie with her new research on catchment area and service area.
Great, thanks so much, John. So one of the things when we did this survey, when our healthcare disparities group received this information back, we were looking at it and we couldn't quite get at the question, who are we not serving? What populations within our catchment area are we missing? So really when we're looking at that second goal that Rolanda spoke about, to identify patients in our catchment area that don't have access to care at our sites, we wanted to find an objective way to obtain that information. So that's what I'm going to go ahead and describe to you guys today. Next slide, please. So before I walk you through some of the maps, I just want to get some definitions as I talk about these things. So for catchment area, it's often defined by geographic distance from a hospital or a clinic. And then service area, that is specific to who are the patients that are actually coming to your clinic? Who are those patients that you're actually serving? So we are so appreciative of all the sites for giving us this information. So when you gave us this information, catchment area was often a list of counties or a list of zip codes that the hospitals identified as the catchment area. And the service area is actually those patients that you've seen within the last year. Next slide, please. So when we're doing this catchment area analysis, we had three main goals in mind. We wanted to compare the demographic data of your site's actual patients to the demographic data of the population within your catchment area. Secondly, we wanted to identify how each site is meeting the needs of the underserved populations. And then we wanted to look at some areas where we can highlight how we can outreach to people that we're actually missing. So when I talk about these goals, I'm actually going to be walking you through St. Louis site, an example of how we can then generate these reports for each of the other sites and draw some conclusions not only within sites, but across sites as well. Next slide, please. The methods that we used, which Rolanda nicely referred to as the innovative methods, are we've been using some geospatial mapping software. So we use a program called ArcGIS, which just draws out some of the catchment area and service area, and then it pulls information from the census data to identify zip codes where high-risk individuals are not served. Our health disparities work group, there's lots of different poverty indicators, but we decided on three poverty indicators when creating the map. So we're looking at federal poverty level, public insurance, and area deprivation index. So we chose these three because for different sites, some might be better than others. So federal poverty level for some sites might be too narrow, whereas public insurance might capture a broader range of people for specific sites. And area deprivation index, which I'll describe later when I show you that map, just further explains multiple factors that can put somebody at risk. So now I'm going to walk you through some of the St. Louis maps to show you what we'll be creating for all the other sites. Next slide, please. So what you're looking at here on the left-hand side in the all-blue map is the catchment area for Knights of Columbus. So if you look in the center of your map, you'll see a black little circle, and that is where Knights of Columbus Child Developmental Center is located. So as you'll see, we border on the left side Missouri, on the right side Illinois, and we're actually located in St. Louis City in Missouri. So we're located kind of smack in the middle of a pretty high needs area. And then if you look on the map on the right, you will see outlined in red, that again is just kind of a zoomed out version
of our catchment area. So the outlined in red is our catchment area, and everything in pink and yellow is our service area. So those are people that we're actually serving. So you'll see that there's some within our catchment area that we're missing, some holes that are not filled in, and you'll also see some areas outside of our catchment area that we're actually expanding beyond our actual catchment area, drawing patients from lots of a broader range than what we define. So we defined in the Missouri, St. Louis City, St. Louis County, and St. Charles County as our catchment area. And on the Illinois side, again, towards the right, St. Clair counties and Madison counties. Next slide, please. So what you'll see here is when we talk about the 3 different indicators that we're using to look at the maps, this is the first one. We're looking at poverty statistics for catchment area. So again, just to orient you to the map a little bit, the black dot in the middle, that is where KOC, our site, is located. And if you look at the legend, everything that's hash marked is those that we, within our catchment area, that we're actually servicing as well. And what I want you guys to focus on is those red and orange areas. So the colors represent poverty statistics for children under the age of 18. So on average, 14.5% of children under the age of 18 live below the federal poverty level. So areas that are highlighted in red, orange, and yellow are greater than that 14.5% of children. So Audrey, can you click on the map? Great, thank you. So what these arrows are pointing to is those are regions where the poverty level is high, but those are people that we are not reaching. So those would be areas that we need to look at maybe doing some outreach to. All right, next slide, please, Audrey. And so this is just another way to look at those red arrows. So those red arrows, these are just selected areas that we're not serving for, that we need to think about how can we outreach to these individuals. So if you look at the top ZEDAs that are primarily, so ZEDAs is how the U.S. Census looks at multiple zip codes. So if you look at some of those top ZEDAs, those are primarily on the Missouri side, and the majority of individuals that are considered high risk for poverty, they're predominantly African American. The bottom 2 zip codes, those are predominantly rural white, and so for our site, those are on the Illinois side. So when we talk about our high needs individuals, oftentimes on the Missouri side, they're African Americans that live closer to the city, and then on the Illinois side, it's a rural white population. All right, next slide, please. So again, this is our catchment area, but now we're looking at public insurance. So when our healthcare disparities work group talked about this, we realized that federal poverty level is on the census, that's 100% of poverty. So that's approximately $20,000 a year for a family of 3. If we're looking at public insurance, oftentimes that's 138% of poverty level, which is about $28,000 per year for a family of 3. So there's still a lot of people that might not make it into that federal poverty that are still very high needs individuals. So that's why we decided to look at public insurance. So here what we're interested in looking at is we want to see the people that are those bottom 3 colors on the key in the left-hand side. So we want to look for that kind of dark orange, pink, and very light pink. So Audrey, if you could click on the map. So again, these arrows are pointing to places in Illinois on the right-hand side and Missouri on the left-hand side where we really need to think about how can we outreach, because these individuals are anywhere from 24 to 70% of the individuals in this area are on public insurance within our catchment area that we are not serving. So next slide, please. So this is that same table that we showed you for poverty, but again, this is looking at public insurance. So on that very far right-hand column, you'll see a range from about 34 to 62% of individuals are on public insurance, and predominantly African American with some rural white. Next slide, please. The third way that we can look at this is using something called the Area Deprivation Index. So what the Area Deprivation Index is it looks at increased risk of adverse health outcomes or health events that aren't just due to one lone variable. Because more often than not, when people have adverse health effects, it's due to an interaction of several factors. So what you see when you look at Area Deprivation Index is it's that traditional bell curve. So the average is 100. So higher scores indicate a greater neighborhood deprivation. So when I walk you through the map, the average, we're interested in areas that are above the average of 100. So for St. Louis, 80% of those in our catchment area that are greater than average, so that have an area deprivation reach. So what St. Louis looks like is very different than what UC Irvine looks like because of the different populations that we serve. So we will be generating reports for each site to look at different recommendations for them. And then we're going to look at how we can aggregate this information across the site. So let me give you a couple examples of each of those. Next slide, please. So for St. Louis, in these selected areas, those areas that I highlighted, we need to identify why aren't people in those zip codes coming to our site? Is it because they lack transportation to get here? Is it because their insurance is not accepted? Is it because there's another clinic in that area where people are primarily seeking services? We need to understand why aren't people coming to our site, and then what can we do to reduce the barriers for those individuals in those zip codes coming to our site? Next slide, please. And then when we look at this information across sites, we can look at race and lots of other indicators, but if we look at just St. Louis and UC Irvine, our two kind of pilot sites that we did this on, in St. Louis, in our catchment area, it's 21.8% African American, but those within our service area that the U.S. Census identifies as African American are 15.7%. For UC Irvine, that's a bit different. They have a predominantly high Asian population and Hispanic population. And if you look at their Asian population, and again, it doesn't split it up, unfortunately, because this is what we get from the census, and their catchment is 18.6% Asian, but 19% of those that are coming to their service, that live in their service area, report being Asian. Next slide, please. And then if we look at the aggregate information across the sites, if you look at those three indicators, percent below poverty, public insurance, and percent of those with area deprivation index above that average of 100 being served, you see that St. Louis, we serve, our poverty is about 82.3% being below poverty being served. And then for public insurance, it's 64.3 for us and 64.7 for UCI. And then the reason that UCI does not have an area deprivation index score is because the highest score for them, they fell below that 100. So they don't have anybody that is above 100 being served. So again, these are just 3 different indicators and ways we can look at things. Next slide, please. One more slide, please. So the next steps for the maps are for each of those sites that submitted the zip code level data and their catchment area data, we will be creating a report with some of the maps for you, and we'll be helping you to identify those in your catchment areas that are not being served. So as a site, you can think about what are the barriers? Why aren't people in those areas able to reach our centers? And then we'll be able to look at overall discrepancies between site catchment and service areas. Next slide, please. So based on all of the work that our Healthcare Disparities Work Group has done, the extensive literature reviews, the initial survey, and now the catchment area surveys, we have some specific recommendations. So we need to think about ways that we can reduce some of those ethnic differences between clinicians and patients being served. So in some instances, it's just not going to be possible to hire a more diverse staff. So are there cultural competency trainings that might be possible? Is there a way that we can add more interpreters if needed? A second recommendation is to think about how we can standardize population reporting. So we saw from the survey that in some instances, some sites are able to obtain information about their autism-only patients. Some collect data on a broader range of patients with developmental disorders. But if we're going to really get at having some good, clean data on healthcare disparities, it's really helpful to make sure that we're recording that information in the same way. And then again, as you saw with the maps, there needs to be very detailed recommendations, but they have to be site-specific because each area is serving such a different, unique population. Next slide, please. We recommend, as a Healthcare Disparities Work Group, that all the ATN sites should track the following information. There was some variability amongst which sites collected which information, and again, we're not sure how much control people have over this, but we suggest race and ethnicity, primary language spoken and use of interpreters, parent literacy level, parent education, and family income. And finally, when we think of all of this coming together, the survey and the maps, each site needs to find ways to understand why specific individuals in their catchment areas are not accessing their centers. And then we need to find ways to reduce barriers for these individuals to come to our centers. Next slide. So thank you all so much for your time. Jean, Rolanda, and I are happy to answer any questions or respond to any comments that you might have.
That was a great presentation, Katie and Rolanda. Cool stuff. Thanks very much. Audrey, do we have any questions coming from our audience?
Yes, we do have a couple questions. Let me just pull them up. So we had a question for specifically Katie and Rolanda, since your site is in the Missouri area, about where the Ferguson area is located, and if that's in your catchment area, and if that's an underserved area as well.
Yeah, we would have to pull up probably exactly the data, but yes, it is in our catchment area, and it's kind of like north of St. Louis City.
Yeah, definitely we have it in our catchment area. Definitely I have patients from there, but we can identify specific zip codes if anyone is interested. Yeah.
If I remember the map correctly, that was an area that was pretty white colored on your, was that the public, the poverty level or the public insurance map? Is that correct?
You know, I would have to pull up which county. I mean, looking at the maps, I don't know off the top of my head exactly which area the white areas are, so that's probably something we need to look at a little bit further.
Okay.
So then another question kind of related to the maps, the catchment area maps with the zip codes. So the question is that it appears that the analysis of disparities is focused on home zip code. Are you also able to compare racial, ethnic, or other kind of mixes for catchment areas versus service areas?
I don't think I quite understand the question. Could you say it one more time, Audrey?
Yeah, so the kind of the home zip code data is zip code specific. Do you have kind of, are you able to piece out more specific data within each zip code for race, ethnicity, other kind of things that I guess you would see disparities?
Yeah, so for each zip code, we can pull the specific information. So whatever is reported in the census, we can use that. So the census records everything zip code level. So for each zip code, we can pull out you know, race, ethnicity, public insurance use. There's lots of different indicators that we could use.
Okay, great. So then we also have a couple questions about how many of our 14 ATN sites submitted catchment area data. Was it all or kind of a subset of the sites?
We received it from all sites except for one. And then the tricky thing is that we're struggling a little bit with the 2 Canadian sites with how we can use that data because we've been using the U.S. Census data. So they've been so great working with us, but we're not quite sure how we're going to be able to use the information that they gave us with their postal codes. So that's one of our holdups.
Okay. And then another question related to parent literacy and how that was measured. So was it literacy in English or by the family's kind of first language? Just a little bit more specifics about how parent literacy is measured.
We just asked a general question about parent literacy, whether that is actually being measured or not. And I think it's just by self-report, you know, in your primary language. That's, you know, what we assume.
What is that question roughly worded like, John?
Okay, I have to look it up. Hold on a second.
I don't know if that's quite the same as highest education level attained, or if it's...
This is item number 15 in the survey that asks, does your site track levels of parent literacy? Yes or no?
Okay.
Which site?
Across.
Okay, so I'm wondering how we would, whether that, I honestly don't know what to ask a parent or any person about their literacy level. I would probably start with asking about their educational, you know, highest degree attained or something like that. But that would be something for us to look into is how to appropriately ask that question and track that, because it could be very useful.
I agree with you, Dan. That's a good point. I do think that parent literacy, you can get there with parent education as well. And, you know, from the statistics, you can see that, you know, more sites collect that information. But it was noteworthy just to see that actually one site does collect that information. So
yeah.
Yes, and this is Maureen.
This is Maureen.
So the thought being that maybe we could, you know, work with, if we felt this was important, we could work with that site. But I also just wanted to say the reason I was part of developing the survey, and one of the reasons we asked both the level of education and literacy, is because we know that when we're working with children with neurodevelopmental challenges, just because they completed a certain grade doesn't necessarily mean that they have achieved a certain level of literacy. And due to the likelihood that some of these things run in families, we wanted to make sure that we were acknowledging that education level and literacy could be very different specifically for our population.
Sure. Sure.
So
are there any other questions?
Yeah, another question kind of related more towards the recommendations and kind of next steps for addressing some of these disparities that you all have identified is whether or not you all have thought about or if there are any plans to kind of work with parents from some of these underserved populations to get them involved in really helping brainstorm ways to increase services and increase awareness.
Yeah, John, you want to take this or do you want me to?
Oh, no, I can speak to this. Yes, we wanted to actually, one of the steps that we proposed was to come up with focus groups with families that we identify as underserved. But, you know, in the interest of time, we weren't able to really do this at this point. But it's definitely something that we thought about. It was very important to us. And we don't want to necessarily give up on this, so this is something that we want to pursue in the future. Katie, do you want to add anything to this?
No, yeah, that's exactly what we talked about. I think the one additional thing we said is really think about ways that maybe we could use the family advisory committees to help connect us with families to really get their opinion and understand why we're missing them. And Audrey, if I can just comment on a previous question that we had, we looked up the zip codes for Ferguson, and one of the areas that we are missing is not Ferguson. So we actually are, it is a very high needs area in the St. Louis area, but we are serving multiple patients from that area. So I just wanted to respond to that individual's question.
Great, thank you so much. Unless anyone had any other questions, I think that's all that I have as far as questions go.
Great. I think that there's some great stuff here, and I really appreciate the way that our presenters today and the Disparities Work Group looked at different types of disparities, looking certainly at income, but also at ethnic groups and cultural issues that might be at work in different sites. I think as our sites look at this and collect this information and examine that, we're able to see where we are at each site. And each site obviously is going to be unique in terms of who they are adequately reaching and not reaching at all. I think that the techniques that were described today are some really useful tools for helping us identify what we don't know. Once we've done that, as you look at some of these factors, there may be some that you're not going to be able to have a tremendous impact on, but others that you can. So it might, for example, it might be easier or more effective if we were to identify an area of a cultural group where we can do some outreach, meet with them in their community, in their churches and in their other gathering places, and make them more aware of developmental problems, encourage them to seek screening and to come to our sites for their evaluations. That might be something that is more within your reach to do as a site than, for example, trying to change the funding pattern for the assessments as you're trying to serve some of the lowest socioeconomic groups. Each site, again, is going to find that there is a population that they are not getting at and find some ways of getting to them a little better. So I think that there were some wonderful ideas presented today during our presentation. I think it's also useful for us to look at this as part of our overall mission of trying to improve care for everybody with autism, identifying them and then providing them that ongoing care. And if we're not gathering this information or examining it on the front end, then there isn't an opportunity for us to try to improve that aspect of our care. If there are no other comments or questions, I do want to thank our presenters today from UC Irvine and from St. Louis University for a very detailed, very well prepared, and very informative presentation. And if I don't get a chance to talk to folks through a webinar or other conference call in the next few days, I want to wish everybody a wonderful holiday season. With that, I'll turn everybody loose a little early today.
All right.
Thanks so much.
Thanks so much, Dan.
Everyone.
Folks.